Hi, welcome to the start of our Neuro series. This will be a 4-part recording that I will do individually. This first portion is Cognition Part 1, which is Module 23, and Encephalopathy, which is 11A. This first recording has its own PowerPoint, and then the subsequent 3 recordings I will do separately. You do have separate outlines, but it is just one long PowerPoint. There's a lot to this neuro content, and I'm going to streamline it and make it easier for you. So be sure that you have your outline with you so that you can follow along and take some notes. Okay, so let's talk about what cognition is. Cognition is really complex, and it's our mental ability to acquire, store, retrieve, and use information. So I always think of the brain as a computer. I put information into it, it can store it, it can retrieve those memories and all of that knowledge that I have, and I can use that information. The changes we see in cognition can be acute, which are abrupt changes, and those are usually reversible. And then we have the chronic ones, which are slow changes, and those tend to be irreversible. And thinking of dementia is a good example of that chronic slow progression of cognition. So when we think of cognition, your book defines that as confusion. It's increased difficulty in thinking clearly, making judgments, and focusing attention. There's lots of reasons people are confused. And then we have disorientation, which is the inability to correctly identify one or more of the parts of being awake, alert, and oriented to person, place, and time, and situation. And then we have psychosis, which is really a general term used to describe an abnormal state that alters the individual's thought processes and their ability, and how that impacts their perception of reality. And that will really come into play when we do Cognition Part 2 and talk about some mental health disorders. So let's talk about mental status and LOC, level of consciousness. So we have consciousness or arousal, and that's the awareness of self and the environment. So that is being awake and alert and oriented times 4. And then we have cognition, which is the ability to produce a response. So you ask a patient to do something like give me a thumbs up. That has to go into their brain, it has to process and come out as an action of showing you thumbs up. Now in your notes there are terms for you under level of consciousness for you to understand. You can also look at table 11.2. So it talks about being confused, what lethargic is, obtunded, stuporous, comatose. As we go through those, your Glasgow Coma Scale, which is what we use to assess this and give us an idea of where this patient is going to get lower. So you may see somebody who's comatose. They're unconscious, they're unaware, they're unable to respond to the environment. That can last from days to weeks, and the person may regain consciousness, they may die, or they move into what's called a chronic vegetative state. So it's usually we refer to this as a vegetative state, but your textbook did talk about unresponsive wakefulness syndrome. And this is where people cannot respond to their surroundings. They do have periods of alertness, but it's unresponsive alertness. And they may groan, they may move, they may have some reflexes, but they are not responding to their environment, which is where it gets very difficult, especially for family members in this, because they may even kind of smile, but they're not responding to their environment. This is from diffuse brain damage. Brainstem function continues, which means their heart beats and their lungs breathe. They may even have sleep-wake cycles, but they are not responding to stimuli, and they can live like this for years. The other piece that you may not have heard of is called lock-in syndrome, and these are people who are awake and they're capable of thinking, but they're paralyzed and can't communicate. So the best example of this is somebody who is in surgery and they wake up during surgery and they're still paralyzed, but they're waking up from their surgery. This really can happen in our spinal cord injured patients. And then we have brain death, and that is cessation of brain function, including functions of the cortex, higher level brain function, and brainstem. It is confirmed by blood flow studies that show no blood flow to the brain. So if you were taking care of a patient who's been declared brain dead, they are dead. They can have a flat or inactive EEG. They don't have those brainstem reflexes. If we put the vent on hold or pause, they do not breathe. And this is the time that we talk to the families about what the patient had. The patient expressed any wishes that if they became brain dead, would they want to donate their organs? So this does lead us into organ donation or organ procurement. So our local organization that takes care of organ procurement is called LifeGift, and this is the time that we would call LifeGift in. We really should call them in early if we have somebody that has a significant brain injury, was in a motor vehicle crash, something along those lines that they are not doing well. They have a Glasgow coma of 3, and this just looks bad. So you have just a couple of bullet points here, and this is really to kind of just give you a little idea about this and to tell you what the nurses do. And certainly we do see this within the ICUs. So the patient's been declared brain dead, and organs such as heart, lungs, liver, kidneys, pancreas are donated. So this is where it's important for individuals to decide how they feel about this one way or the other, and to let their families know, because when these conversations are happening, the patient no longer has the ability to tell us. The nurse's responsibility is to identify and refer potential donors for organ procurement. We are required for every death to call LifeGift. After the patient has died, we are looking at donating tissues, so skin, ligaments, eyes, not organs. Brain death is where we're looking at organs, where we want to, we are there to keep the patient stable physiologically so that we can ensure that we have vital organs, and LifeGift comes in. So LifeGift is going to come in at the time that the physician has come in and told them what this looks like. And we really here LifeGift wants to have that conversation with families. We are there just to support them. May have started a small conversation, but really LifeGift takes this on. And our job is to provide emotional support and information to the family, to work with our OPOs to obtain consent, and to give compassionate and sensitive care to these patients. If the family has okayed organ donation, we will work with LifeGift. They will get those organs placed across the country, come up with the time that that's going to be done. And it actually a lot of times happens late in the evenings or even overnight. And I think you probably all have seen those honor walks where hospital staff lines up in the hallway, and we honor those patients for the great gift that they are giving by giving their organs to those who need it. All right, so let's talk a little bit more about Glasgow Coma Scale. So this is split up into eye-opening, best verbal response, and best motor response. So I found a nice little JPEG here for you. So the scores range from 15 to 3. 15 is awake and alert and oriented. 8 or less is considered coma. You do have some definitions of ranges of what's mild injury, moderate injury, and severe injury. We give them the best response. Now, if you are awake and alert on a vent, the highest you can score is 11, because you only get 1 for verbal because you can't speak to us. And we're probably not going to call you awake and alert and oriented. We're going to say that you're awake, you follow commands. You write me notes, you shake your head yes or no. I just don't know that you're oriented because I can't talk to you and have you respond appropriately that way. If you can't do anything, you do get a score of 3. So when we are doing this, specifically, there's a couple of places that we have to really think about what we're doing that may trip us up so that we do this correctly. I am not going to give you a test question that says the patient can do this, this, and this and expect you to Total Epiglotticoma Scale. That is knowledge base, and that's basic math. What you need to do is to be able to interpret their responses, to know what that looks like on glaucoma, and know what our responsibility as the nurse taking care of this patient, what it means and what we need to do. So when we look at eye opening, it's spontaneous. I walk in the room, you open your eyes. Do you open it to voice? Do you open it to touch? Or do you not open your eyes at all? Now, what you have to remember is you don't want to go in the room and say, oh, look, Bob's laying in the bed and Bob didn't open his eyes. So I'm going to go over and say, hey, Bob, open your eyes, while I'm touching Bob on the shoulder and poking him on the shoulder, because I gave him a verbal command and I also touched him. So if he opens his eyes, I don't know which one he opened his eyes to. You do one. You call his name a couple of times. Does he not open his eyes? If he doesn't, then you move to touching him to see if that works. Speech. So it is the best response. So are they oriented? Times 4. Are they confused? Which means that they know who they are. They can answer questions. They may say it's the hospital, but they don't know what the date is. They may not know what time of day that is. Are they using inappropriate words or an inappropriate response? And that is, they say something to me, but it absolutely doesn't answer the question I just asked them. It just doesn't make any sense. Or they just say crazy word, they put a bunch of words together in a sentence, but the sentence doesn't make any sense. That is inappropriate response. Incomprehensible is sounds, moans, and groans. And then certainly no response. And that is what we would give somebody who's intubated or who has a trach who can't talk to me. And then we're going to get down to motor. And this is also where people have some problems with this. So I need you to obey commands. So I'm sure you've seen nurses say, hey, can you squeeze my hands? And they put their fingers in the patient's palm and the patient squeezes their hands. And we all know that all family members know that their loved one in the bed is supposed to be able to squeeze their hands, because I've seen it all over TV. But what we have to be careful with is you do need to remember that just putting your hands in their palm, they can close their palm as a palmar reflex, just like you learned in newborn babies. If you put your fingers in their little hands, they're going to grip it, and you can actually pull them up off the mattress because their grip is so strong. That is a palmar reflex. I need to know that you do more than have a reflex, which is why we may say, can you give me a thumbs up? Because that has to go into your brain. You have to process that information and come out with a response. Localizes to pain means if I pinch them over on their arm, and we are using noxious or painful stimuli to get a response, and that's going to look bad to family, and we have to explain that this is important, that or we've got to have a response. That if I pinch them over on the left side, they take their right arm and they're crossing midline and they're pushing my hand away as to say, ouch, that hurts, stop doing that. That's localizes to pain. Withdrawals is when we apply nail bed pressure to them and they will pull back from me. That is withdrawal. They are moving away from the pain. Localizes to pain is they're pushing the pain away to make it stop. Withdrawals to care means they're just moving away from the pain. And then we have our posturing of decerebrate and decorticate. And those are both bad. So here's a little picture I found that I like of decerebrate, which is also called flexion, or decerebrate, which is called extension, and decorticate, which is called flexion. Many years ago, I heard that they were getting rid of decorticate and decerebrate and going with flexion and extension, and I've yet to see that happen. So you can hear both terms. This can be from noxious or painful stimuli, or it can happen spontaneously. It is a sign of brain damage. And each side can actually posture differently, and that is severe brain damage, and that is very, very bad. When you're looking at this, you're actually looking at their arms. Their legs will actually stiffen and their toes both point, so that doesn't tell you anything. So decorticate flexion is towards the core. They pull those arms up towards the core like they're hugging themselves. And this is a higher glaucoma. This is actually 3. Decerebrate is they have extension and those arms are out and they actually roll their fists out. They'll have some turning of the shoulders, and that is decerebrate, which is a glaucoma of 2 for movement, and no movement is 1. So these are both very difficult, and you do need to watch to see if they do this. Okay, so let's talk about some other assessments. So we might do motor and sensory. So we're really looking at movement. Do we move all extremities, which is why we do bilateral comparison. Squeeze both of my hands. Give me thumbs up on the right. Give me thumbs up on the left. Have them point their feet down towards you. So you put your hands at the foot and say push down like on a gas pedal, and we are doing bilateral comparison. Then you put your hands on top of their toes and say pull your toes to your nose, because you're looking for bilateral comparison. You're looking at, do they have muscle tone, or are they flaccid? Flaccid means I can put their arm up and it just falls to the bed. What's their strength? What's their posture and coordination if I'm watching them walk? Do they have symmetry? And then cessation is to touch, pain, temperature, and position. So do they feel me touching them? They need to not be looking. Do they feel pain? We can do sharp and dull. Is it cold? Is it hot? And then position is actually, do they know where their arm is in position to the rest of the body? So the most common motor testing that you're going to see done is actually called arm drift, and this is our little picture of our little elderly lady, and we really do this for strokes. You can do this for head injuries, but we certainly do this for strokes. We have them close their eyes and stick out their arms with their palms up, and we need them to hold it for 20 to 30 seconds, and what you'll see is that arm drift down because they've got a deficit on one side. They may not even be able to pick it up. So that is what an arm drift is. Then we look at reflexes. Our superficial reflexes are corneal, cough, and gag. So if they're intubated, checking cough and gag is very easily. You suction them, that's a cough. You check a gag by doing mouth care and stick that oral yonkers in the back of their throat all the way to the back. If you kind of want to gag when you do it, you've probably got it far enough on the patient, and they should gag on that. A corneal reflex, you do see this in books on awake and alert patients. There is zero reason to do a corneal reflex on anybody who's awake and alert. You do this on people who are comatose, and you take a little bit of cotton and you put it in the corner of their eye, and they should blink because there's something in their eye. That is a corneal reflex. You can also do a blink reflex. Is if their eyes are open, you take your hand and move it quickly towards their eye, kind of like you're about to slap them in the forehead. Please don't hit your patient. And you're going to blink and actually withdraw your head because you see something coming towards you. That is a blink reflex. And then our pathological is our palmar reflex. We've talked about a suck reflex. They will suck on that ET tube. These are things baby has. Or a plantar reflex, which is a Babinski reflex. And Babinski stay until a child walks or are gone by age 2. So if we see the suck plantar or Babinski on an adult, this is very, very bad because they are present in babies. So what you do for Babinski is you run you can use some closed hemostats. I used my closed pin. You don't want to use anything sharp, and you go from the heel up the foot and then kind of arc over towards the great toe, and what you're looking at is flaring of the great toe, and that is a positive Babinski reflex, which is a bad sign. Okay, so let's talk about language and memory. So we can have aphasia means they can't speak. So we can have global aphasia, which is inability to speak, name objects, repeat phrases, or follow commands. And then we can have, so that's global. They don't have anything going on. What they could have is expressive dysphagia, which is difficulty in speaking. Aphasia means unable to speak. And it's called Broca's because it's the Broca's area of the brain. And so what that means is that they have trouble speaking fluently, being comprehensible, and if they can't speak, it's really just a few short words. So it's expressive. Receptive dysphagia, or Wernicke's part of the brain, means that they can't comprehend language in following commands because they can't receive the information. Expressive is they have a hard time with the information coming out into words. Then we can have dysarthria, which is motor dysfunction affecting the muscles in speech. Words cannot be articulated clearly, usually as a result of cranial nerve damage or muscle impairment. So it's physically muscles can't work. And dysphagia is certainly difficulty swallowing liquids and food. So this is all where our speech language pathologists, SLPs, or we call speech therapists, come in to help these patients. And then certainly checking their memory, which is short-term and long-term. And we all know that what people keep is long-term memory. It's the short-term memory that is difficult. So other assessments that we can do can be cranial nerves. That is figure 11.3 and table 11.1 in your book. And I did pull that cranial nerve picture out of your book. Mainly we're going to look at things like pupil assessments, which is cranial nerve 3, 4, and 6, and then we'll do focused cranial nerve assessments like stick out your tongue, raise your eyebrows, shrug your shoulders, can you smile for me, and we're looking for symmetry of the face. Asymmetry, which means one side moves, like you can smile on one side, is an abnormal finding. We are looking to see that the pupils respond to light in one or both eyes. Any change in pupil response in one or both eyes can indicate increased intracranial pressure. That's what ICP is, and neurological deterioration, and that is really important. So what we do want to look is, are pupils equal, round, and reactive to light? So that's Pearl. And so we chart that. If you're charting Perla, you are charting about accommodation, and you need to make sure that you know what it is and you actually are checking for it, because what it is not is if you hold your pen light out and bring it towards their face and their eyes cross, that's called convergence. That is not accommodation. Accommodation is having them look far away, then looking at something close up, and then far away and close up, and what happens is their pupils will change size because they're looking far away and close up. That is accommodation. So if you don't check that, chart Pearl. Do not chart something that you did not do. So you can also check, what you may also see is this doll's eyes, which is called the oculocephalic reflex. This is done in patients that are, as one way that we are determining, are they brain dead? And so a normal or negative response is when the head is turned to the side, the eyes move in the opposite direction. And we really are moving that head to the side fairly quickly. So if you suspect a spinal cord injury, don't do this. A positive response is when the head is turned, the eyes remain looking forward. So you may see physicians do doll's eyes, or even nurses. So let's talk about respiratory function and acid-base imbalance. So it's important that we do assess pattern and rate, and changes in respiratory pattern and rate can indicate a neurological deterioration, and we are really looking for Cheyne-Stokes respirations, which are periods of apnea followed by slow respiratory rate, and then deeper and maybe faster, and then it gets slow again, and then you have apnea again. So I found this little kind of waveform JPEG, and this is what you are going to see. You can see this on a vent. It can sometimes be difficult, but it is a classic sign of increasing intracranial pressure, possible herniation, and it's bad. So let's talk about ABGs. And the two values we're really looking at is PaCO2 and PaO2, because I promised you ABGs on most all of your tests. So your cerebral vessels will dilate or constrict based on this acid-base imbalance. PaCO2 is a potent potent agent affecting cerebral blood flow. If your PaCO2 is higher than 45, you will have vasodilation of your cerebral vessels, which means you get more blood flow to your brain, which means you increase their intracranial pressure. If your PaCO2 is less than 35, then you're actually going to get vasoconstriction, which means we don't have enough blood flow and enough PaO2 going to the brain. So we want our PaCO2 levels to stay between 35 and 45. They may choose to keep it pretty close to 35, but we really need it to be normal unless we are given a specific order by a healthcare provider to keep it something different than that. And if they do, they would be a tiny bit less than 35, but 35 to 45 is what I want you to remember. And certainly that we know that if we don't have enough oxygen to our brain, we're going to have problems, and PaO2 levels less than 50 will mean our cerebral vessels dilate to get more blood flow up there, which will certainly increase the pressure in their brain. Okay, so we're going to finish up by talking about encephalopathy. And this is defined as global brain dysfunction, and it can range from confusion to coma. And it results from a primary neurological condition, which could be a head injury, stroke, or something like a brain tumor, or non-neurological causes like infections, so meningitis, encephalitis, metabolic disorders like liver failure, renal failure, toxins like lead poisoning, or idiopathic, which means we just don't know. You've already had some information on encephalopathy because of your liver disease that you studied last semester in level 3, so you do know about hepatic encephalopathy. We can also see chronic traumatic encephalopathy, or CTE. That's been around. We've used that term frequently. There's a Will Smith movie about it, which I never can remember the name. And this is associated with multiple concussions and results in progressive decline in memory and cognition. They can have depression, aggression, poor impulse control, personality changes, Parkinsonisms, like they'll start to tremor and shuffle, and signs and symptoms of what looks like Parkinson's, and they can have suicidal behaviors. This is a form of dementia. We do need to recognize this. There has certainly been news cases. We see this in usually pro sports. Football, certainly, but it can be other things as well. And we have now had a recent case of somebody who went to the NFL office in New York and started wanting to shoot, and actually left a note that said, "Please look at my brain." And this was somebody that never played NFL football, only played in high school and college, and did have CTE. So this is kind of a scary thing, which is why we are seeing changes on rules for concussion, which we'll talk about, because basically a concussion is a traumatic brain injury, and we're seeing rules about how long you can play with those. You can't just be put right back into the game. So the way we're going to see encephalopathy is people are just getting confused and we can't figure out why. So they're going to come in. So tests we may do a lumbar puncture to make sure this isn't meningitis. We're going to do a CT and an MRI. We're certainly going to do a CBC, a basic metabolic panel to look at renal function. We may look at liver function. We may need to do a swallow evaluation to make sure that they can still swallow. Are they having difficulties? We worry about aspiration. So they're going to come in confused with altered mental status. We do see a lot of people admitted with altered mental status, or the other most common one that I see is UU, unconscious, unresponsive. They're going to have loss of memory, difficulty concentrating, processing information. They could be drowsy, lethargic. They could have a coma, so they're going to span the gamut of all of those. They can have personality and behavioral changes. They can have some motor symptoms like jerky eye movements, poor balance, difficulty coordinating their muscles. They can have seizures. They can have twitching and tremors. So we're going to see a wide range of things for them. We might have to intubate them to protect their airway. We may have to sedate them too if they're having lots of movements. So really the treatment is treat the cause, find the cause. And safety is what's most important. So we need to closely monitor them. We need to get a sitter. We need to have the bed alarms on. We're going to take their vital signs labs, think of airway, do an EKG, make sure we don't have a cardiac issue going, reorient them regularly, make sure they have the things that they need, like glasses and hearing aids, so that that's not making this worse. Do seizure precautions. You talked about that last semester, so you know what seizure precautions are. Have a calm environment. They may need to be NPO if they've had swallowing difficulties, and to make sure that we check and make sure that they can swallow appropriately. And we're going to need to educate the patient and the family. Okay, that wraps up Cognition, these, my apologies, these are a little bit long, but we've got lots of content to cover. Thanks.